I mean, heterogeneity is definitely a problem in meta-analysis, systematic reviews. It always will be. It's interesting to me. They tried to pull out like 6 to 8 different data points here, yet reported like low or moderate heterogeneity for the studies. I'm a little bit skeptical, if you really were to dig into it, that the heterogeneity is really as low as they're reporting. And their conclusions off their abstract, they reported 3% reduction in mechanical ventilation, or 3% reduction in mortality, 5% reduction in mechanical ventilation. That's a number needed to treat of 1 in 33, a number needed to treat of 1 in 20 for those two outcomes. So those are population-based numbers needed to treat, really. Like, it's like aspirin for ACS, some other stuff. It's not, this person maybe needs some steroids, this person doesn't. When you're talking about numbers needed to treat like that, what you're really talking about is something that you're either going to do all or nothing for everybody to really see a measurable benefit in like your hospital system, your area. So I would agree with you, like, it's not really ready for prime time. There's probably too many other issues with the study. It's a bit unfair for them to conclude in their abstracts that there's up to a 3 and 5% benefit for those two outcomes in particular, when the rest of the paper doesn't really support that.
But yeah, I agree with you, Richard. I would absolutely, if whenever I'm admitting a COPDer with pneumonia, I usually give it to them anyway, because I haven't really met the COPDer with actual COPD that wasn't wheezing a little bit. And the separation of a COPD exacerbation from a pneumonia is a little bit messier than we're really comfortable stating. A lot of COPD exacerbations are probably low-grade pneumonias because they get better with antibiotics. And a lot of pneumonias may really be reactive airway disease. We see that in the kids, where you get the chest x-ray on the 5-year-old that doesn't have a true bacterial pneumonia, and the x-ray looks a little bit like a pneumonia. So it's a little bit messier than we'd like to believe with reactive airway disease versus true consolidating lower lung infections.
For those of you who've been fortunate enough to rotate in the MICU recently, what is the practice in the MICU? Although it's a little bit of a loaded question, because the people that are up there are going to be complicated pneumonias for the most part, even if they are community acquired, because they're going to be a sicker patient population, et cetera. But are the MICU attendings generally favoring using steroids in these patients?
So the people who are getting to the MICU tend to be, some of them are hypotensive. So they're using the steroids more as a stress dose steroids, or putting them on a steroid taper for those reasons, more so than if they don't have COPD or anything else, they aren't necessarily giving them steroids.
I think it's complicated because a lot of the people in the MICU have underlying lung disease. So that's when they're getting steroids. But the ones that I've seen that just have pneumonia and no underlying lung disease, no.
So me personally, my practice actually changed slightly with this. If I have a severe pneumonia patient, I'm actually going to strongly consider steroids if I'm admitting them to the hospital, especially if I'm admitting them to the ICU and they're not at high risk for complications. You got a brittle diabetic, sure, I'm probably not touching you. But if I'm admitting you to the ICU, I think almost all the signal from these studies were for the severest of severe pneumonias. Still think that those that you're admitting to an ICU setting, and honestly, most of the pneumonias that I'm admitting that are real pneumonias and not, I kind of look at the x-ray a little bit and maybe they have a pneumonia. I think a lot of those that are getting them into the hospital have the potential for benefit, and I don't see as much the harm. But I was not routinely doing that before this. So I'm going to use prednisone for most of my folks because it's something I'm comfortable with. The studies used all kinds of stuff, everything from hydrocortisone. Yeah, I do like 40 of prednisone or something like that. They were using solumedrol, or methylprednisolone. They were using hydrocortisone. They were using all kinds of different stuff in these studies. So it's all over the place. But I think that you guys did a really good job. Let's give them another hand.